Good morning, America, good afternoon, Europe, and good evening, Asia. On behalf of the International Education System, I would like to welcome everyone to our first nephrology webinar, which is focusing on COVID-19 and implication on kidney disease. My name is Miklos Molnár. I am one of the staff transplant nephrologists in Methodist University Hospital, James D. Easton Transplant Institutes in Memphis, Tennessee. I also serve as an associate editor physician scientist in University of Tennessee Health Science Center. Today, we will have three different speakers focusing on different areas of kidney disease and kidney patients. So I would like to welcome Dr. Ernesto Molmenti. There are some background noise. Yeah. So Dr. Ernesto Molmenti is a vice chairman of Department of Surgery, chief of surgical innovation, and director of kidney transplantation, professor of surgery, medicine, and pediatrics at Zudbeck School of Medicine at Hofstra, Northwell, Long Island, New York. He co-authored 250 peer-review manuscripts and served in different editorial boards. He also authored 5 books. Dr. Molmenti is a member of American Society of Transplant Surgeons and also served in different committee at UNOS. Dr. Molmenti's current interest includes transplant innovation as well as medical technology. He has recently proposed a new approach to direct organ donation and incompatible kidney chains. Throughout his membership in the UNOS National Kidney Transplantation Committee, he contributes to mandate redesign of kidney allocation system in the US. Dr. Molmenti also has multiple patents in medical devices. Today, Dr. Molmenti is going to talk to us about COVID-19 implication in kidney transplant population. Right after Dr. Molmenti's presentation, Dr. Connie Ree is going to take over and going to talk about COVID-19 implication in dialysis population. Dr. Connie Ree is a practicing nephrologist, physician scientist, and assistant professor of medicine and public health at University of California, Irvine. Dr. Ree pursued her clinical nephrology fellowship and postdoctoral research training at the Combined Birmingham and Women's Hospital, Massachusetts General Hospital Nephrology Fellowship Program, and also completed her Master of Science and Epidemiology degree program at Harvard School of Public Health. Dr. Ree joined the University of California Irvine Division of Nephrology as a faculty in 2013. She's currently serving as a division director of clinical and translational research, director of dialysis quality improvement, and associate director of outpatient hemodialysis, associate director of urgent emergent dialysis, associate fellowship program director, and acting associate chief. Dr. Ree research has been centered on metabolic and endocrine derangement in kidney disease, as well as dialysis outcomes in the end-stage renal disease population. Dr. Ree research has been supported by multiple NIH, National Kidney Foundation, and American Thyroid Association grants. Thank you so much for both Dr. Molmenti and Dr. Ree to join us. And after these two presentations, the final presentation is going to be done by Dr. Jeff Pearl, who is going to focus on treatment of AKI-required renal replacement therapy in patients with COVID-19 infection. Let me introduce Dr. Pearl. Dr. Jeffrey Pearl is graduated from Faculty of Medicine, University of Toronto, and completed his postgraduate training at the University of Toronto in both internal medicine and nephrology, and received a Master of Science in Clinical Epidemiology from the Harvard School of Public Health. Currently, Dr. Pearl is a staff nephrologist at St. Michael's Hospital in Toronto, and associate professor of medicine at University of Toronto. In 2016, he was awarded the John Maher Young Investigator Award by the International Society of Peritoneal Dialysis. His primary research interest and clinical practice focus on improving survival and quality of life for patients on home dialysis. Dr. Per is a primary investigator in the peritoneal dialysis outcomes and practice pattern, the PDOP study. Again, thank you so much for all three presenters to join us today. And for the audience, I would like to ask you to put all the questions in the chat box, and at the end of the presentation, I'm gonna share this question with the presenters and answer these questions as well. From now on, let me just give you some numbers. As you all know, COVID-19 is all over the place in the world. As of today morning, based on the Johns Hopkins University COVID-19 website, there is 2.3 million confirmed COVID-19 cases in the world, with 160,000 deaths. Mainly in the most cases is still in the US and Spain and Italy as of today morning. But I think there is no part of the world which is not infected with this disease. We know more and more about the kidney, how it affects the kidney and our kidney patients, but I hope we're going to learn more today in the next 45-55 minutes. So right now, I would like to hand over and move on and ask Dr. Momenti to present his first presentation, which is focusing again COVID-19 and implication on kidney transplantation. Dr. Momenti.
Well, Miklos, thank you very much for that great introduction. I would like to thank INEDSYS and especially Professor Salapathy for this kind invitation to be here. I thought today, let me bring my presentation into the screen. Can you see the presentation? Administrator, can we see the presentation?
Yes, we can.
Perfect. So basically, what I thought we could do today is do a quick review of the COVID-19 evolution, address some kidney transplant reports already published, review a couple of interesting observations on liver transplantation, and then open the field with some of the current observations and a discussion. Basically, the current COVID infection was preambled by a report of 3 patients who on December 27th of 2019 presented to a hospital in Wuhan. One died, 2 survived, and despite not fulfilling all of Koch's postulates, this report provided evidence implicating what eventually would be called COVID-19 in this outbreak. Further along, other reports provided more information and started to delineate what would be our current knowledge on this. Anthony Fauci, at the end of February, in the New England Journal, publishes a summary based mostly on one of the previous articles on the characteristics of this pandemic, basically affecting individuals with a median age of 59 years. At the time, the morbidity and mortality involving mostly the elderly and those with coexisting conditions. Over half were male. No cases in children younger than 15, interestingly enough, with a fatality rate of approximately 2% and an R0 of 2.2, that is the infectivity. The first reported case of COVID-19 in a transplant patient came from China. A 52-year-old man who presented 12 years after a transplantation with a symptomatology and laboratory examination and imaging studies similar to the general COVID-19 population. He recovered after a reduction on his baseline immunosuppression and low-dose methylprednisolone. Subsequently, from Spain, another report of a 50-year-old man who had received his third kidney transplant in 2016, had a history of thymoglobulin induction, and approximately 15 years prior to 15 years prior to presentation, a history of a post-transplant lymphoma. He presented with a fever and, interestingly enough, GI symptoms. Most laboratory values were within normal limits, at least the ones that were obtained, and he was discharged home from the emergency room, only to present 5 days later with a pulmonary and febrile findings and elevated levels of inflammatory markers and a consolidation on his right middle lobe on chest X-ray. His tacrolimus and everolimus were discontinued. He was given HIV protease inhibitors, something that subsequently was proven to be of no major effect, and hydroxychloroquine. He was intubated as of the case report when it was published, and he underwent several changes in his treatment regime. It's interesting because he had an initial presentation with GI symptoms, which has been reported to involve 3 to 5% of COVID individuals. A case of 7 transplants, a series of 7 transplants from London, provides us further evidence. In this case, there were 3 females with a median age of 54. It was a cohort of over 2,000 transplant patients that were followed at 3 different South London hospitals. Of the 7 cases, 2 were managed on an outpatient basis, which shows us that not all the presentations are the same. There's some heterogeneity in the presentation symptomatology. 5 of the 7 required hospitalizations, 4 in the ICU. 1 patient recovered completely by the time the series was reported. 1 recovered. 3 patients with severe disease were diabetic. Immunosuppression was modified in 6 of the 7, and they were treated with supportive therapy. The person whose immunosuppression was not modified was being treated with azathioprine and steroids on a low dose and had a failing kidney. 5 other cases were presented from China, where they also had comorbidities, hypertension, diabetes. 1 had a history of a bladder malignancy. There were 803 cases had been performed, of which 743 were being followed up. The most common symptomatology were a fever and respiratory findings. 4 of the 5 had their immunosuppression decreased, and 1, which was being treated for rejection prior to the diagnosis, continued with a full dose immunosuppression. There were no reported cases, although the authors described this as being a mild COVID infections. A study from Italy of 20 patients, and interesting enough, in this study, they not only report transplant patients, but they also report patients on dialysis, both hemo and peritoneal dialysis, and patients with a chronic kidney disease. Connie and Jeffrey will speak subsequently on this, so I am not going to expand so much on this. But Alberici and collaborators describe 2 phases of approach. The first phase being with a potential treatment for the viral effects, and a second inflammatory phase in which they describe a possible onset of a hemophagocytic syndrome, a hyperinflammatory response that manifests with a progressive lung involvements and ARDS. The management of these patients, which they describe as having multiple comorbidities, was with changes in the immunosuppression And they also describe a very interesting finding that we have also identified among transplant and non-transplant COVID patients, which is a hypercoagulable condition that affects both the arterial and the venous system at all levels, not only peripherally, but also centrally. Though Alberici and collaborators in Brescia were following 1,200 transplant patients. As a result of the massive infections sustained, the transplant center was temporarily closed. 20 transplant patients were admitted. 5 died, bringing the mortality to approximately 25%, at least until the time the paper was published. 4 patients were admitted to the ICU, and 3 were discharged after an average of 13 days. As I mentioned as well, there were some studies on 470 dialysis patients and 5 patients with chronic kidney disease. Now, going back to a condition, there are also multiple other cofactors that are seen here. Once the high incidence of neurological findings in these individuals. This is this case. This is a series of non-transplant patients in which 14% had some type of neurological affliction on admission to the ICU. That increased to 67, almost 70%, when sedation and neuromuscular blockade were withheld. It's unclear whether these findings were purely associated with the COVID infection or whether they were a result of critical illness and withdrawal of medications. Now, several reports have hypothesized that immunosuppressed patients may not be at increased risk of complications in the setting of coronavirus infections when compared to the general non-transplant population. Let me show you two of these reports. Basically, probably the most aggressive report in this subject is the one by Antigua published in Liver Transplantation, where he postulates that no mention is made that immunosuppression is or may be a risk factor in coronavirus infections, including SARS, MERS, and COVID-19, where no fatalities have been reported linked to transplantation, chemotherapy, or any other condition requiring immunosuppressive therapy at any age in both adults and children. He further postulates that although the surveillance of this particular group of patients should continue, there is no reason to postpone any life-saving treatments, such as chemotherapy or transplantation in both adults and children. And he expands that immunosuppressed patients may not be at increased risk of severe complications. A second report by Mazzaferro and colleagues in the Lancet Gastroenterology and Hepatology describes 3 liver transplant patients. Usually these 3 patients, they all died. They were elderly, had multiple recipients, more than 10 years, and were on low doses of immunosuppression. He compares them to some short-term liver transplant recipients, and he mentions a pediatric population, and it's postulated that children may not be that involved. These findings are interesting because there are reports in the literature on liver transplant recipients who were affected by COVID-19. Indeed, in Mazzaferro's series, the 3 who were affected, they all died. As such, let me propose to you some discussion topics, share with you our experience here, and get your opinions. Basically, we've seen that the presenting symptoms seem to be similar to those of the non-transplant population, at least the most frequently encountered presenting symptoms, such as fever, myalgia, cough, and other respiratory findings. In the vast majority of kidney transplant patients, they have imaging findings suggestive of viral pneumonia, although at least in our experience, a significant amount, maybe up to 30%, may not have any major findings on pulmonary imaging. The acuity of the illness seems to be variable. As we saw, some patients were discharged home, others were admitted, some of them directly to the ICU, where they became rapidly intubated. There should be a close monitoring in the setting of lowered immunosuppression. Usually the first approach to immunosuppression reduction in transplant recipients seems to be the stopping of CellCept, of MMF, and Imiran, of antimetabolites. Our immunosuppression is based upon an interleukin-2 blockade that we tend to diminish. Most of the immunosuppression seems to be tacrolimus, which, at least in our experience, the normal levels, we tend to decrease them to about 50% or so of the baseline. It's unclear how the induction therapy affects the COVID infection, whether thymoglobulin or an interleukin-2 receptor blocking agent has a greater or lesser degree of involvement. So far in our experience, we haven't encountered any major discrepancies, but that's still to be determined. Furthermore, we have not encountered any clear evidence that transplant immunosuppression reduces the incidence of ARDS or death. A group, as has been previously mentioned, may have a cytokine storm syndrome, and some form of immunosuppression may be of benefit in this setting of hyperinflammation. Interleukin-2 and interleukin-6 and interleukin-1 blocking agents are currently being tried. So far, I mean, interesting enough, while interleukin-6 and interleukin-1 are being tried, our baseline immunosuppression is based not on any of these two, but on interleukin-2 blockade, which may be a very interesting thing to further evaluate. In the kidney transplant population, the presence of at least one comorbidity is almost universal. Most patients have two or more. Co-infections with bacterial or with other viruses seem to be rare or very rare. With respect to the mortality, we should probably separate in-hospital mortality from the overall mortality. The overall mortality seems to be in the transplant population approximately 10% overall. However, for those patients who are hospitalized, the mortality seems to be in the 25 to 30% range. The morbidity is uncertain yet. It's an evolving topic. There are new findings. We have no proven treatment for COVID. So we have to find on a long-term basis whether there are any sequelae for this. We have also to keep in mind that as we become more and more familiar with the viral infection, we encounter more and more comorbid findings, such as cardiac involvement. There could be a neurological involvement, the hypercoagulable involvement, which brings this to a subject that should be evaluated on a long-term basis. At our center, which we have developed a great way of treating and tracking them thanks to our great team, we monitor patients by telehealth. Another topic that should be addressed is the incidence of acute kidney injury in COVID-infected recipients. In our experience, as well as in what we've seen from other case reports, the incidence of acute kidney injury could be around 50% in those patients who are hospitalized, especially those who are in the ICU setting. We have instituted as well rather than a reactive approach of receiving patients who present with symptoms, a proactive outreach to our patients. We call them and we monitor them to find out if they have any symptomatology suggestive of COVID. We need to evaluate to see how they're doing. And we have identified as well the fact that there's a major socioeconomic factors that affect the infectious conditions. In many individuals who have small households, when a relative of a recipient becomes infected, it may be very difficult for the recipient to isolate him or herself from the infected relative. So in many instances, they become infected themselves. So that's an approach that has to be evaluated, and we need to develop new ways on how to address it. I would also like to thank, this is a hospital where we work, I would like to thank the incredible team that I'm so fortunate to work with, and that I feel pride to be around. That's the end of my presentation. I would like to take any calls, take any further questions as we move along.
Thank you so much, Dr. Momenti. I suggest, because it looks like the audience is a little bit shy, I encourage the audience to type in questions, and I suggest to do the question and answer in the end of the talks, and move on now with Dr. Ree, who is going to talk about COVID-19 implication in dialysis patient. Dr. Ree.
Hello, everyone, and I'm just waiting for our presentation to be uploaded. Perfect. Thank you very much, Dr. Molnar, for your kind introduction, and I'd like to thank the INEDSYS leadership for the opportunity to present to you today. I'd also like to thank all of our healthcare workers on the front lines who are taking care of patients at this time. And I'm a practicing nephrologist and a clinical researcher at the University of California, Irvine. These are my disclosures. Over the next 15 minutes, there are four main areas I want to cover. We're first going to review the scope and characteristics of COVID-19 as the rationale for current infection control recommendations. We're then going to examine unique implications of COVID-19 in the dialysis population, including a recent COVID-19 case at my institution. We'll then move to discussing the prevention and control of COVID-19 in dialysis patients. And we'll close with briefly evaluating potential treatment interventions under investigation. So in terms of the scope and characteristics of COVID-19, as Dr. Malmanati had mentioned, there have been previously known to be 6 existing coronavirus species that cause human disease, including 4 strains of the common cold virus and 2 strains of a zoonotic virus that have been linked with death, including the SARS coronavirus of 2002 in Guangdong, China, and the Middle Eastern respiratory coronavirus in 2012. The current SARS coronavirus 2 is the 7th member of the coronavirus family that is genetically related to SARS coronavirus of 2002. These are different viruses, but both use the ACE2 receptor for cell entry. But this newer coronavirus 2 poses a greater threat than other coronaviruses because it can kill healthy adults in addition to the elderly and chronically ill, and it is transmitted very efficiently with an exponential rate of spread. So on average, a single person can spread disease to 2 to 3 additional people. Now, as mentioned by Dr. Malmanati, in late December of 2019, local health authorities had reported a cluster of pneumonia cases of unclear etiology that were linked to a seafood and wet animal wholesale market in Wuhan, China. And by early January, this outbreak was linked to a novel coronavirus, and the first death occurred in China. By late January, the first cases outside of China were reported in parts of Thailand, Japan, South Korea, and in the United States. And by January 30th, the World Health Organization declared a global public health emergency. In late February, there was a surge of cases in South Korea and Italy and other parts of the world. And by March 11th, the World Health Organization declared a global health pandemic. Now, although some aspects of the transmission are not entirely clear, we believe that the primary source of person-to-person spread occurs via respiratory droplets that can be transmitted as far as 6 feet. An additional important source of transmission includes the touching and infected surfaces and then touching mucous membranes, which include the ear, nose, and mouth. And studies of the viability of COVID-19 have shown that the virus remains stable up to 3 hours in aerosols and up to 72 hours on plastic surfaces. Additional studies have shown that there is widespread contamination of hospital rooms of patients with COVID-19. So in a study of a room of a patient with mildly symptomatic COVID-19 prior to cleaning in Singapore, viral RNA was detected in nearly all surfaces, including door handles, light switches, bed rails, doors and windows, sinks, and toilet basins, underscoring the paramount importance of disinfection in the home and healthcare setting. Now, the incubation period of COVID-19 is 14 days following exposure, although most cases will develop symptoms within 4 to 5 days. And in a modeling study of 181 confirmed COVID-19 cases from China, it was estimated that roughly 3% and 98% of infected patients will develop symptoms within 2 and 11 days, respectively. Now, in contrast to the common cold, flu, and seasonal allergies, COVID-19 has a more protracted length of exposure and is more characterized by shortness of breath. But similar to these other conditions, COVID-19 may also manifest with rhinorrhea, sore throat, fever, and headaches, body myalgias, as well as diarrhea. And as highlighted by Dr. Mominetti, there are multiple end organ complications of COVID-19 that may include pulmonary, immunologic, cardiovascular, GI, hematologic, dermatologic, and head, ear, nose, and throat complications. And an observational study of cases from Wuhan, over a quarter of cases of critically ill and deceased patients were found to have acute kidney injury. Now, in terms of COVID-19 and dialysis population, hemodialysis and peritoneal dialysis patients are at heightened risk of COVID-19 because of their older age, multiple coexisting comorbidities, and their suppressed immune systems. Furthermore, both end-stage renal disease and COVID-19 disproportionately affect patients of minority racial ethnic background. Hemodialysis patients are also particularly vulnerable because of their frequent travel to dialysis units and their clustering within dialysis shifts. Now, at the University of California, Irvine, my institution, we also recently reported a case of COVID-19 in one of our dialysis patients that was published by one of my colleagues, Dr. Anthony Puri, and my division chief, Dr. Kamiar Kalantarzadeh. This was a 56-year-old male with a history of end-stage renal disease due to IgA nephropathy who had been on hemodialysis for 3 years, who also had a history of coronary artery disease and hypertension, for which he had been taking losartan and an angiotensin receptor blocker. This patient had actually returned from South Korea from business travel in early January, but it was not until early March that he manifested symptoms. And notably, similar to the first case that Dr. Mominetti presented, this patient actually had nausea, vomiting, and diarrhea, predominantly GI symptoms, as well as a low-grade temperature. Now, after 5 days of having these symptoms, this patient was actually seen in 4 different emergency departments, an outpatient clinic. Oops, I think we lost our slides here. Oh, thank you. Was seen in 4 different emergency departments, 1 outpatient clinic, and 2 different dialysis centers because he was on business travel. But he subsequently developed respiratory symptoms and was admitted to the hospital, where he started to receive broad-spectrum antibiotics, including azithromycin. He progressed to hypoxic respiratory failure and ARDS, as well as atrial fibrillation with shock, and was subsequently given hydroxychloroquine, tocilizumab, an IL-6 inhibitor. He was deemed not to be a candidate for remdesivir because of his ESRD status. Now, unfortunately, after 18 days of hospitalization, the patient passed away because of a cardiac arrest. And as you can see on these serial chest x-rays, there was rapid progression from an interstitial pneumonia to ARDS. And his CT chest showed multifocal ground glass opacities with a peripheral distribution. In other parts of the country, there's also been a high burden of cases reported, and a case series from 9 hospitals in Seattle also reported a high prevalence of CKD among their COVID-19 cases. Now, there are unique challenges in terms of the prevention and containment of COVID-19 in the dialysis population. In terms of historical precedents, during the Ebola epidemic of 2014, as you may remember, all patients who had suspected disease were referred to hospitals for dialysis and treatment. And dialysis was exclusively provided in the inpatient setting in the United States because there were only a small number of infected patients, and these were referred to a few selected centers of expertise. But in contrast, COVID-19 is far more challenging to contain because it is transmitted very quickly by pre-symptomatic or mildly ill patients. And in certain parts of the country and across the world, hospitals, emergency departments, inpatient wards, and ICUs are overwhelmed by the number of cases. Therefore, dialysis patients who don't have serious complications must stay at home and continue their dialysis at outpatient units. In fact, the United States Center for Disease Control advised that as of early March, patients, they advised that hemodialysis could be performed among clinically stable COVID-19 patients in the outpatient dialysis setting, and among the ESRD, USRD networks, they highlighted that COVID-positive patients who are stable should be treated with outpatient dialysis, emphasizing that hospitalization should be limited to those who very much need it. Now, regulatory bodies, now over the course of this epidemic and now pandemic, regulatory bodies as well as professional societies have issued guidance in terms of the prevention and control of COVID-19 in the dialysis population. And this really involves 6 essential steps in the management of our patients. So first, there should be education of patients and healthcare workers with regards to the basics of hand hygiene, as well as respiratory hygiene and coughing etiquette, and in the appropriate use of PPE. Second, screening of all patients is required before entry to dialysis within designated screening locations, and there has to be an action plan for triage for patients with symptoms to various testing sites, hospitals, or even COVID-19 dialysis units. Third, in terms of the management of patients with undiagnosed symptoms or confirmed illness, face masks should be worn on arrival at all times. There needs to be separation of positive and symptomatic versus negative and asymptomatic patients, as well as assignment of specific healthcare workers to these patients and rapid notification to local health authorities. And fourth, there should be judicious management of resources, including tracking of PPE use and inventory. At our own center, we started to use recycling extended use of our PPE. Fifth, in terms of planning, there also has to be appropriate management of the workforce. So at our own institution, we've also started to prepare for a potential surge, not just in the present setting, but for also a potential surge that has been anticipated in the fall. And so we have started to plan for potential deployment of not only our staff, but also physicians in the event of increased disease activity and a decrease in workforce due to illness. And finally, at our center, we've been able to transition some of our in-center hemodialysis patients to home dialysis in order to promote social distancing and eliminating the need for transportation. This will be a topic that Dr. Jeff Pearl, who's an expert in the field, will discuss further. This has also been able to be achieved with the collaboration and alignment with our surgeons for urgent PD catheter placement in this context. Now, in response to COVID-19, our Center for Medicare and Medicaid Services, which funds our dialysis and provides oversight, has recommended certain steps with respect to screening, treatment, and triage of patients. They have mandated that we screen all patients, staffs, and visitors with 4 specific questions in relation to signs or symptoms of respiratory infection or fever, if patients have had any contact with COVID-19 cases or persons under investigation, if there has been international travel within the past 14 days, and if there has been residence within a community where there's rapid spread of COVID-19. Among patients who have undiagnosed signs and symptoms, CMS has also mandated that patients wear face masks at check-in, and they maintain these until leaving the facility. Our staff have been trained to ask patients about fevers or respiratory symptoms immediately upon check-in, and they've been encouraged to check temperatures. Staff are advised to inform patients prior to coming to dialysis unit to report fevers or respiratory symptoms for planning, and visitors with signs or symptoms of disease are advised not to come to the unit. Our own center has taken a step further by actually requiring that all of our patients and healthcare providers wear face masks throughout the entire facility. We require temperature checking of all of our patients as well as our healthcare providers before entering the dialysis treatment area. And we actually do not allow visitors, including family members nor dialysis transportation personnel, to come into our treatment areas. The CMS has also made important recommendations with respect to the use of PPE in undiagnosed respiratory symptom patients, including the use of isolation gowns. So these need to be worn over or used instead of a laboratory coat, as well as use of gloves, face mask, and eye protection. And in our own center, irrespective of the presence of symptoms, all of our healthcare workers are using isolation gowns, gloves, and face masks. And these recommendations for PPE are aligned with that of the World Health Organization and CDC in terms of confirmed COVID-19 cases and persons under investigation. Now, there are 3 additional measures that I would also want to highlight in terms of the mitigation of spread of disease. In terms of universal masking, although CMS, CDC, and other regulatory bodies do not mandate this at this time, our own center is requiring universal masking of all of our patients and our healthcare providers in the dialysis treatment areas. And although there remains to be a lot of debate in terms of the evidence and the science of the benefit of masking, from observations in parts of Asia where universal masking is pervasive, we've seen very effective control of the spread of infection within hospitals and among healthcare providers and of patients. Second, social distancing is key with respect to mitigation of spread of disease and prevention. So in our own center, we use innovative approaches in terms of social distancing. So in our in-center hemodialysis patients, we have staggered scheduling. We've staggered scheduling in order to reduce crowding in patient rooms. We required maintenance of 6 feet of distance among all patients and healthcare providers in all directions during treatment. We've opened additional dialysis shifts and have also transitioned some of our patients to less dense shifts in order to reduce crowding. Some of our clinicians have been using telerounding with patients. And as mentioned, we've transitioned some of our in-center hemodialysis patients to home dialysis. Among our home dialysis patients, we've been utilizing monthly telemedicine visits for our stable patients. And we have sought to reduce excess visits to the unit by reducing the number of excess laboratory draws and trying to alter certain medication administration, such as using oral iron in the place of IV iron. And for our healthcare workers, we are actually mandated by CMS to have monthly quality meetings for our dialysis unit, but we now transitioned this to video conference for only core staff members. And for multidisciplinary meetings of our patients with our dietitians, nurses, and social workers, we're also doing this completely by video conference at this time. A third essential measure in terms of mitigating the spread of disease includes clustering and distancing of confirmed COVID-19 cases and persons under investigation. So if there are a few number of cases, patients can be placed in separate rooms with a closed door. According to CMS and CDC, patients can be placed in a hepatitis B isolation room if a patient is also hepatitis B surface antigen positive, or if the facility does not have other Hep B positive patients requiring the room. But if this is not possible, a corner or end of row station away from the main flow of traffic can be used. But in cases where there are multiple patients with suspected or confirmed COVID-19 cases, a center may want to cluster patients and as well as designated staff in a designated unit. And this is actually what our center is doing. Alternatively, patients can be clustered within a designated shift, such as the last shift of the day. Now, in closing, I want to talk a little bit about the management of disease as it relates to the dialysis and non-dialysis populations. So there's been wide debate with respect to the use of RAS inhibitors in both the ESRD and non-ESRD populations, which is a first-line antihypertension drug in our dialysis population. So COVID-19 uses the ACE2 receptor for cell entry, and some preclinical studies suggest that RAS inhibition increases ACE2 receptor expression. However, at this time, there is insufficient data to determine if this translates to humans, and to date, there have been no studies of RAS inhibitors' effects in COVID-19. Furthermore, there is concern that the abrupt withdrawal of RAS inhibitors in high-risk patients, such as those with heart failure or myocardial infarction, may result in adverse outcomes. So at this time, professional societies and experts do not recommend stopping RAS inhibitors in patients who are currently using these medications. As you're all well aware, nutrition is also an important cornerstone in the management of our dialysis patients. And there's evidence that there's heightened risk of contracting common illnesses with poor health habits such as inadequate sleep or psychosocial or physical stress, including inadequate nutrition. And there's been evidence that certain interventions such as vitamin C or vitamin C-rich foods can prevent the common cold or duration and severity of illness. So an important step that we can take to ensure mitigation and to ensure, I think, decreased susceptibility of our patients is to mitigate and immediately correct protein energy wasting in our dialysis patients by ensuring there be adequate protein and energy intake. Very recently, the Infectious Disease Society of America issued their living guidelines for the treatment and management of patients with COVID-19 across the broader population, not per se specific to dialysis. But the main point that I want to highlight with respect to these recommendations is that these interventions that have been discussed, such as hydroxychloroquine, lopinavir and ritonavir, tocilizumab, and IL-6 inhibitor should be used in the context of a clinical trial. However, there has been increasing excitement about the recent data published on remdesivir, a nucleotide analog that has shown some benefit in vitro studies of COVID-19. In a recent publication of the New England Journal of Medicine, it was shown that among 61 patients who received remdesivir on a compassionate use basis, over 2/3 of patients experienced improvement in symptoms in terms of oxygen requirements, and 57% of patients were successfully extubated. Investigators reported that there was no evidence that remdesivir was associated with nephrotoxicity, but it's important to highlight that in this study and in ongoing trials by this sponsor, patients with an eGFR of less than 30, dialysis, and CVH are not being included at this time. So in conclusion, the COVID-19 pandemic poses a major threat to both the healthy and chronically ill because it is transmitted very efficiently with an exponential rate of spread. Respiratory droplets and infected surfaces are key sources of transmission. Therefore, social distancing, hand and respiratory hygiene, object decontamination, and universal masking are essential. Finally, ESRD patients are a vulnerable population who require congregation for life-sustaining dialysis, and early recognition and management with rigorous screening and case identification are recommended, and distancing and clustering of COVID-19 cases and persons under investigation may contain infection. These are some potential resources that can provide further guidance in terms of prevention and containment of disease in the dialysis population. I'd like to pay acknowledgement to a number of mentors and collaborators. Thank you.
Excellent presentation. I would like to move on and turn over the microphone to Dr. Jeff Pearl, who is going to focus on the AKI management and the role of PD in this population. Dr. Pearl.
And so I'm focusing mostly today, and thank you for having me, on peritoneal dialysis for the treatment of acute kidney injury. Peritoneal dialysis is my clinical and research interest. I must say that we were sort of thrown into the use of it for acute kidney injury treatment by virtue of the COVID-19 pandemic. And in fact, here in North America, in the United States, peritoneal dialysis was one of the earliest treatments for acute kidney injury. And so this is an initial case report in JAMA in 1946, looking at the treatment of uremia after acute renal failure by peritoneal irrigation. And this case report came after reports were already being performed in the 1920s and 30s of PD for acute kidney injury. Only until 1946 was it actually published. So as Dr. Ree had mentioned already, this is sort of the landscape of the COVID-19 pandemic in the United States, and the red represents the hot spots. The real, very severely affected area is in the New York City area. And in fact, in the New York Times newspaper, there was a plea to try and get a huge amount of supplies for acute dialysis to the New York area, where my colleagues are reporting an incidence of acute kidney injury of around 20 to 30%. I'm just going to take a minute in general to provide my thoughts on acute kidney injury and COVID-19, since there isn't a presentation on that per se. Some pathologic case series from China post-mortem have shown that most of it is acute tubular injury. There also is some evidence that there is direct virus in the kidney on biopsy specimens, implicating a role that the biopsy may be involved in some of the acute tubular injury, although we need more research on that. And lastly, one of the things that we know is that if we look at the SARS pandemic, acute kidney injury was associated with a 92% risk of death compared to 8% without acute kidney injury. So initial reports from Wuhan, China were about 3 to 5% of cases were acute kidney injury. Some centers reported as high as 15%, but in the United States, some centers are reporting 20 to 30%. And so there's been an overwhelming use of hemodialysis and CRRT. And in response to that, because of shortages of CRRT and hemodialysis capacity, acute PD has been used. And this is just one interventional radiologist tweeting about his experience in New York placing PD catheters for acute kidney injury. And I would say in the New York area, there's probably been 40 to 50 patients been treated with acute kidney injury in discussion with my colleagues. So why would you think about PD for acute kidney injury? I think the main reason why it's been used is because of resources or capacity for acute dialysis and CRRT has been overwhelmed. It is suitable for PD in hemodynamically unstable patients because it is continuous renal replacement therapy. There's minimal infrastructure. You can pretty much start an acute PD program with very minimal infrastructure. And that's why in many low and middle income countries, this represents a very viable option to treat acute kidney injury. It avoids vascular access, and other sites for other purposes can be used, like for vasopressors in critically ill patients with limited sites. And one of the things that's emerging in the critical care environment of COVID-19 pandemic is a coagulation problem. We're seeing a lot of patients clotting. We're seeing a lot of challenges with the CRRT circuits and maintaining anticoagulation during dialysis. And so peritoneal dialysis really avoids systemic anticoagulation. So no concern in patients with bleeding diatheses or in patients with coagulation challenges. And then lastly, if you are using automated PD, you can set the cycler up outside and theoretically have less nursing time with direct patient exposure. What are the concerns, though, regarding PD for acute kidney injury treatment? You have less predictable fluid removal rates, and we know that some intensivists are very uncomfortable not using CRRT, where they can monitor hour-to-hour ultrafiltration. Solute clearance is a concern, particularly in hypercatabolic patients, in terms of the dose of PD that we're delivering. There's concerns about peritonitis, and probably one of the big concerns of mine in centers that are doing it with little experience is leaks, particularly because we're using a catheter very shortly after we've placed the PD catheter for peritoneal dialysis cycles or exchanges. And one other concern is the critical care has pushed back in terms of what is the impact of putting PD fluid on respiratory biomechanics in mechanically ventilated patients. So these are some of the concerns. And this is actually a study from Brazil looking at, in mechanically ventilated patients, what is the impact of putting in PD fluid. And in fact, you can see there's a very modest increase in intra-abdominal pressure in mechanically ventilated patients with the installation of PD fluid, but this is very mild. And so I wouldn't worry too much about the impact of intra-abdominal fluid on the mechanically ventilated patients. And in fact, a follow-up study to this compared hemodialysis and peritoneal dialysis patients and found no real big differences in intra-abdominal pressure. If you are placing a PD catheter, one of the ways that you can adjust dwell volume is by monitoring intra-abdominal pressure. So you want to have the patient in a horizontal position, and you can measure this once the PD catheter is in place. This is a protocol here, but the bottom line is once you have PD fluid in, you can cater the amount of fluid you're putting in to titrate the intra-abdominal pressure. And usually we don't want an intra-abdominal pressure above 18 millimeters of mercury. Above 18, we would consider that increased intra-abdominal pressure. So 18 or below is what we would be targeting. This is a systematic review. There's also been a Cochrane meta-analysis, about 24 studies comparing PD versus hemo. The methodologic quality was low, but did not show any mortality difference in patients treated with acute PD compared to patients treated with hemodialysis. This is also one of the largest studies that contributed to that meta-analysis. This is a randomized control trial from Brazil. 120 patients were randomized to high volume PD versus daily hemodialysis. What you can see here is urea, creatinine, bicarbonate were all metabolically managed similar. On the bottom pane, potassium, sodium, and glucose were similar. The sodium did go up in the patients on PD, presumably because there was some free water movement across the aquaporin. And so what you would see here is free water transport in absence of sodium, leading to sodium sieving and hypernatremia. One interesting outcome with PD compared to hemo in this study was a shorter time to resolution of acute kidney injury. And this might be because of favorable hemodynamics in these patients as they were treated with PD. What do I consider the absolute and relative contraindications? Of course, if you've had a recent breach of the peritoneum, if someone has peritonitis or some bowel compromise or inflammation, severe hyperkalemia, PD removes potassium slower than intermittent hemodialysis. Patients with severe respiratory failure and pulmonary edema, this would not be an option, I would think. If you're using lactate buffered PD solutions, and in the United States, for example, there's no bicarbonate buffered solutions, and you have severe shock liver with lactic acidosis, the liver can't convert the lactate to bicarbonate. So you really can only do PD in that circumstance with bicarbonate PD solutions. If you have high baseline intra-abdominal pressure, this would not be an appropriate treatment. And then lastly, in prone ventilated patients, there's been one case report of successful PD, but I would think logistical concerns would preclude us from using it. And we know that we're prone ventilating many of our COVID-19 acute kidney injury patients. So historically, when we think about PD for AKI, it was a rigid catheter that was placed at the bedside. It had a high risk of peritonitis and was short-lived, being only used for 72 hours. Now I would say most acute PD is being done with a flexible Tinkoff PD catheter. You can have one cuff or two cuffs, and this can be a long-term access for the patient if they fail to recover from the acute kidney injury episode. The methods of insertion really will be dictated by what your local expertise is at your center. You can do it percutaneously at the bedside. You can do it under fluoroscopic and ultrasound guidance. These patients are too sick for surgical catheter placement in the OR. And I'd say the most important thing is you need an operator who's motivated and enthusiastic. As per ISPD guidelines, you should use prophylactic antibiotics at the time of PD catheter insertion. And because you have a short break-in period of 24 to 48 hours, you want to reduce the risk of leak. And at the time of PD catheter insertion, the two things that you can do to reduce the risk of a leak is make sure that there's a purse string suture in the deep cuff. When the deep cuff is being placed in the rectus muscle, your surgeon should place a purse string suture. The deep cuff should also be placed with a paramedian incision to allow that catheter cuff to adhere to a rectus muscle. If you put the catheter midline, there may not be enough tissues to hold on to. And then lastly, you probably don't want to choose obese, diabetic, or immunocompromised patients to start. They would tend to have a higher risk of leak. And if the leak develops, you have to hold PD for 3 to 5 days and re-challenge it thereafter. This is just some guiding principles for a PD catheter, for a PD prescription. You want to start with low dwell volumes and increase it right away. You can do manual exchanges or cycler-based PD. It may be more difficult to do manual exchanges for volume removal, and you can run the PD every 60 minutes continuously for 24 hours in intubated patients using a cycler. Tidal PD, leaving a reserve volume in the peritoneal cavity, can be considered if the PD machine is alarming because of prolonged inflow and outflow. And you want to make sure that if that's the case and you're using low volumes, you can set tidal PD, leaving a reserve volume of PD with the automated PD machine. Patients with COVID often need aggressive ultrafiltration, so start with higher concentrations of glucose. You can supplement potassium intraperitoneal. When the potassium falls below 4, these patients will tend to become hypokalemic. What's the optimal dose for acute kidney injury in PD? That's not been well studied. And of course, if you're dosing antibiotics and other drugs, we don't have good studies for dosing of antibiotics in acute kidney injury and PD treatment. Our closest modality to compare to would be CRRT. This is the example from the Brazilian experience. They actually start with 2 liters right from the start. But if you're a center that's just trying to get expertise in this, you would start with lower volumes and build that up over the course of 1 to 2 days. I wrote this article that's been submitted right now on PD for acute kidney injury for publication with my colleagues from the US. This is a sample protocol, so your catheter placement is according to your local expertise. These are some prescription considerations if you're doing automated PD or manual exchanges, whether you're in the intensive care unit or the ward. And this is sort of a cheat sheet in terms of some of the things to think about when you're prescribing PD, like heparin, potassium supplementation, a good bowel routine, and always reevaluating the prescription and the modality if your metabolic and fluid removal goals are not being met. These are some monitoring parameters for monitoring for acute PD. And in terms of complications, these are really the 3 main complications that you would worry about when delivering acute PD. And of course, it's really important to have a good bowel routine. So what are the take-home points? PD for acute kidney injury is a team approach. You have to have buy-in and a culture change from your critical care staff for this to be implemented successfully at your center. There is no doubt that PD access, insertion, and reliability and speed is key, as is nursing expertise. The nurses need to learn how to do this. If you can learn to do CRRT, this is easier than CRRT. You need to develop and implement a standardized protocol, such as the one I showed you on the previous page. And if you're just starting out, I would say consider your initial candidates carefully and more restrictively. Pick patients with lower risk factors for leaks. Pick patients who've been on hemodialysis for acute kidney injury treatment who are now more stable and have a longer time to recover. You can convert them. You can put the PD catheter in and allow the catheter to heal. Perhaps pick non-ventilated patients to start. And of course, it's always good practice to stop if you're not achieving your goals after 2 days of therapy and reevaluate the therapy. These are 2 of my colleagues in the US, Dr. Vikram Agarwal over here and Dr. Vesh Srivatana, both of whom have started and have implemented acute PD programs at their centers in the United States, who helped contribute to the article that we published or are publishing. Thank you.
change the environment and the approach for PD in the US. I think we have to wrap it up a little bit because we are running out of the time. So I would like to ask one or two questions for each presenter based on the feedback from the audience. So first to Dr. Momenti. So can you kindly comment us about how about the new kidney transplant procedures, or are you what's your recommendation on living donor and deceased donor kidney transplantation and procedures in the highly infected area? Is it safe to do?
Thank you for the question. Let me share recommendations, transplant surgeons, so we can all see them. Basically, for deceased organ donors, they're at the present time, at least in the area, they're mostly on hold. The recommendation when they come back is both donors and recipients immediately prior to the transplant and as close as possible to the transplant. We should also consider the extent of penetration of the infection within the donor hospital and the community and possible symptomatology exerted by it. We also have to keep in mind that the acquisition and spread of the virus have been reported in the US through both live and deceased donor surgeries. When dealing with live donors, we also have to anticipate the fact that there could be unexpected outcomes based upon a COVID infection, be it at the time of the transplant, slightly before, or post-transplant. So at the present time, transplants are kind of on hold. We're planning to reopen at least the center where I am within the next weeks, based upon the outcomes. Keep in mind as well that we also have to determine what resources are available to it, since basically hospitals are being or were being taken care of COVID patients to 80 or more % of their capacity. So the fact that a complication in a transplant may lead to an ICU admission, that may be detrimental to someone who comes with a COVID infection. So at the present time, it's a highly fluctuant state where very few, if any, transplants are being performed. That's basically in response to that question.
Thank you so much. One more question to you. So this question is basically focusing on patient with mild COVID infection. So do you see any benefit starting any treatment, including azithromycin or plaquenil, in patient who is not needing to go to the hospital? So basically an outpatient setting. And do you recommend to stop antimetabolites on these patients and change the immunosuppressive medication regimen for this mild?
Well, azithromycin has not been proven to be of any effect so far in the COVID population. Decreasing MMF could be of help in symptomatic patients or in patients who have been shown to be COVID positive. That would depend on a case-by-case basis. Increasing the immunosuppression doesn't seem to be of any help, so we should consider when to decrease the MMF, which will be the first immunosuppressant to be decreased in these cases. Now, keep in mind, please, when we decrease the immunosuppression, we have to keep a very close eye on these patients, since they can reject at one point or another. Let me add one more thing, since
what's your comment on what's your
basically we have this block. It's been mentioned that there are other treatments, and BCG was also mentioned at some point. There's a treatment with among the questions on how to treat bladder cancers. There are currently other treatments such as MR13 and BCG that have not been shown for either proactive or reactive to have not been proven either beneficial or detrimental, that they're being studied at the present time, among other treatments.
Thank you. So back to Dr. Rees. So what's your recommendation? What's UCL practice about reuse N95 mask and PPE after a few days, 5 to 7 days? Do you have any experience or recommendation on that one?
To reuse, actually our own institution is implementing processes for reuse. They have, I don't know specifically what protocol they're using. I think some approaches that are described in some resources include UV radiation, as well as I think hydrogen peroxide, I think cleaning, not direct cleaning, but some vapor, and I think also, I think moist heat. I don't know, I don't believe that there's clear evidence with respect to COVID-19 in terms of, I think, efficacy, although I think there's some historical precedent with H1N1, but some institutions, including ours, are implementing use with these cleaning procedures. At our own institution, I'll tell you, and I think there's a lot of different practices that are being used at different centers, at least within the US. I just went to see a COVID-19 person under investigation yesterday in the hospital, and we were only required to wear a surgical mask as well as face shield, gown, and gloves. So we actually were not required or actually given, N95s, to wear in that context. But I think it may be different at different institutions. Good question.
Last question is to Dr. Pearl. How safe the PD in renal transplant patient? Can we do PD in transplant kidney transplant patients?
If the question is in general for maintenance peritoneal dialysis, acute kidney injury aside, yes, you can. There's certainly no contraindications to PD because of having a history of transplant, and outcomes are similar. And we published on that using American and Canadian data. If you're talking about PD in the acute kidney injury in the renal transplant recipient, I would consider that patient group an immunosuppressed group, and we do know that mechanical complications, including leaks after PD catheter insertion, are seen with higher incidence in immunocompromised patients. So I'd be a little bit concerned about using it right off the bat. I might put a PD catheter in if that's a long-term acute kidney injury and give it a longer healing period. The one drug that I have been burnt many times about leaks in is sirolimus. So if you have a transplant recipient on sirolimus, you really need to stop the sirolimus if you're going to entertain PD, because if you leave it on, these patients just leak forever. So that's my one caveat to PD in renal transplant patients.
That was really useful. So I think it's 10 minutes over the time, so we would like to close the session. Thanks again for the audience, and also for Dr. Momenti, Dr. Pearl, and Dr. Ree as well to join us today. Thank you so much. Stay safe. Thank you.